All right, autoimmune disorders. So our autoimmune disorders are also referred to as our connective tissue disorders. There's over 100 types. So the main two that we're going to talk about is our rheumatoid arthritis and lupus today. But with our autoimmune disorders, antibodies attack the healthy cells and tissues, and it does not recognize it as itself. So it triggers that immune response. With rheumatoid arthritis, it's a chronic systemic disease that's characterized by chronic inflammation of the synovial membranes of the joints and affects many organs: respiratory, cardiac, muscles, eyes, skin. The antibodies attack the healthy tissue. The IgM and IgG bind with antigen complexes, and then through phagocytosis, it destroys those cells. And then there's a release of the cytokines that affect lipid metabolism, coagulation, insulin resistance, and endothelial function. Can also affect and cause hyperemia, which is an excess of blood in the vessels, fluid accumulation, pannus formation with vascular granulation tissue that erodes cartilage and destroys bone. It can affect any body system, and the vasculitis part of it can lead to organ failure. So combination, environmental and genetic, so female hormones predisposes people, and as well as infectious agents. Signs and symptoms. So these would be classified, so the signs and symptoms are the bigger portion of the RA that I want you guys to concentrate on. So these would be classified as the early signs and symptoms. There are always periods of exacerbation and remission, but some of the earlier symptoms: malaise, muscle weakness, loss of appetite, generalized aching, joint edema and tenderness, subcutaneous nodules, morning stiffness, so they have more limited range of motion in the morning, and potentially a low-grade fever. So then more late symptoms and manifestations, then osteoporosis, severe fatigue, anemia, weight loss, subcutaneous nodules, peripheral neuropathy, vasculitis, pericarditis, fibrotic lung disease, Sjögren's syndrome, and renal disease. We've got that Sjögren's syndrome, a couple slides here. And I don't know if that's exactly how you pronounce it, but that's how I pronounce it. So here's just the main differences between RA and OA. So your osteoarthritis and rheumatoid arthritis. Your rheumatoid arthritis is generally younger females, 35 to 40, emotional stress triggers, inflammatory, bilateral and symmetric. The upper extremities are affected first, and it is systemic. Osteoarthritis is generally older, still more common with females, aging, obesity, trauma, degenerative. It may be unilateral, weight-bearing joints, and it is non-systemic. So the couple different syndromes that are associated oftentimes with RA, Felty's syndrome, they develop hepatosplenomegaly and leukopenia. And then there's Kaplan syndrome, where they develop nodules in the lungs, and can also develop this pneumoconiosis, I think that's how I pronounce it, which is that coal miners disease, and also associated with asbestos, as they get that, it looks like that on the x-rays. And then Sjögren's syndrome, dry eyes, dry mouth, dry vagina, and it can occur with lupus as well, but it attacks the healthy cells that produce saliva and tears. So our diagnostic tests, many of these are done with a lot of our autoimmune disorders: your CRP, your ANA, albumin, SED rate, that's looking for inflammation. The rheumatoid factor, of course, is going to be specific to your RA. Globulin, your red cell count shows anemia. And then they might also do synovial fluid biopsies that shows that it's cloudy or yellow. Treatment: preventing pain and inflammation is a big thing, of course, and also trying to prevent joint damage and deformities and promote ADLs. So balancing rest with exercise, trying to get adequate sleep and even napping. Exercise program, 10 to 15 minutes of range of motion, 2 to 3 times a day. Hot packs can help, heat lamps, paraffin application. And then there's different stages. So stages 1 to 4, and 4, of course, is the more severe stage, and it can be terminal at that stage and cause extensive damage along with organ damage as well. Our meds, we know our NSAIDs are pretty common to help with RA. And then you also have your DMARDs, your disease modifying anti-rheumatic drugs. So sulfalazine is one of those, immunosuppressant agents, and hydrochloroquine, your Plaquenil is common, also with lupus as well. Many of these are for a lot of the different autoimmune disorders. Methotrexate is a common one that's used with RA patients, but you need to be careful with it or know your population that's taking it, because since RA can affect younger women, if they are, of childbearing age, it can cause birth defects. So they need to be aware of that if they're trying to get pregnant or get pregnant, that they need to come off of that. And then of course our steroids.
Isn't methotrexate one of the drugs that they give for chemo? And it can cause like breast cancer?
I'm not sure about that one with the methotrexate as far as causing it. I mean, a lot of the autoimmune, like a lot of these meds, like DMARDs and stuff like that, also are given with, which we'll talk about cancer and stuff like that with our next test. So you will see a lot of similar or the same medication used in different cancers and autoimmune disorders. But I'm not sure about that specific question as far as the methotrexate. I'd have to look that one up. Yeah. Let me write that down so I don't forget.
I just asked because I understand why they would do immunosuppressive because of like the inflammation, but just like the risk of cancer, I don't know if it would be worth it. But obviously this PowerPoint says that, so I understand. It's just
I'm not sure. I'm not sure. I just said not sure. I have no problem admitting that I don't know. As far as the rest, you don't need to concentrate on all these different meds. I mean, there's so many different types. And like I said, a lot of these you'll see when we start talking about the cancer stuff too. So we'll look at those a little bit more closely when we talk about cancer in specific. So don't concentrate on all these specific medications as far as that goes. Just like I said, the most common one is our NSAIDs and our DMARD, like our sulfalazine and that methotrexate. Those are going to be your most common ones with both RA and your lupus, actually. So then you have lupus. So with lupus, it's a chronic inflammatory autoimmune disease that involves multiple organ systems. It is difficult to diagnose. They will have an abnormal ANA titer, the positive lupus prep test, an elevated SED rate, and will have decreased renal function oftentimes, especially later on in the disease. So discoid lupus is when it only affects the skin, but systemic lupus then of course is systemic and is more autoimmune. The ANA affects the DNA in the cell nuclei, immune complexes form, which then causes our kidneys to dysfunction. And then vasculitis occurs that deprives the organs of blood and oxygen. So when diagnosing for discoid, they just do a skin biopsy, but then systemic, again, a lot of the same tests, but then the specific antigens that then are related to lupus, a CBC, electrolytes, renal function, cardiac enzymes, livers, and clotting factors, because it can just affect everything. Care for lupus, again, with pain and swelling in the joints, they get that real identifiable butterfly rash. Hematologic anemia, leukopenia, thrombocytopenia, cardiac can result in pericarditis. Renal, they can develop nephritis that can result in renal failure, which it can be life-threatening because sometimes it can occur rapidly. CNS, psychosis, seizures, cognitive disorders. We've already got pericarditis up there. Raynaud syndrome, abdominal pain, nursing management, providing support, patient education, and drug therapy. Exercise program, physical therapy, managing weight loss, back braces. So there's the specific drug therapy then too, often a lot like your RA. So they'll get those steroids. Plaquenil is really common with lupus, and your NSAIDs, and hopefully you can it can get them into some remission. So then we have scleroderma. So scleroderma then is essentially the hardening of the skin. They have that crest syndrome. And I'm totally drawing a blank on what that stands for. It totally left me. Oh, I swear, some days it's like everything's in there, and then the next day it all leaves me. Yeah, it's drawing. Clearly, it's not super important to memorize what the crest stands for because I can't remember it.
Is it the calcinosis? Like, 'cause you have calcinosis, Raynaud's, esophageal. If you look.
Yes.
Okay.
Yes, it's those ones. Yes. Oh, it's right there. It's right in front of my face.
I was like, wait,
that's gosh. I'm like I'm just focusing on the crest, and I'm like, what is that? Yeah, there it is, right there. So it's all right there. So the sclerodactyl, yeah, I can't even say the word, skin changes, and then the spider-like hemangiomas. So scleroderma is one that it also can be systemic, or which I don't have a specific slides versus the systemic and then just the skin, but it can become systemic and cause hardening of the organs and stuff as well, and can become much like lupus in the fact that it really can wreak havoc on your organs as well, and can become life-threatening and really decrease the quality of life. All right, and that is the last one for that. So with the autoimmune stuff, as I already mentioned, just more focus like on the early and late signs and symptoms with your RA, and then there's the treatments in general with both of them, because they are very, very closely related, being autoimmune in that. Okay, so now we have our HIV. Let me pull up. There we go. All right, so HIV, HIV and AIDS, there are 1 million people living with HIV in the US, and there's about 56,000 new cases each year, and it has globally killed more than 25 million people. Transmission, sexually, breastfeeding, sharing IV drug use equipment, perinatal transmission can occur within a few days after infection, tattoos and body piercings, and of course, exposure to blood and blood products. It is not transmitted though by all of these things. So it's a blood-borne pathogen. So these things will not cause transmission. The biggest way to protect ourselves is standard precautions, just like with anything. I mean, that's why standard precautions are so important, because it protects us against many of just from acquiring any disease process. So HIV is no exception. So hand hygiene, soiled patient equipment, using our PPE, using standard precautions with patient resuscitation and placement, respiratory hygiene, cough etiquette, just making sure you're using those standard precautions at all times. This is just a video of the pathophysiology with the HIV cell entry, if you choose to look at it. I'm not going to play that today, but if you so choose, it is there. So the big key players with our HIV is our CD4 and T lymphocytes and our viral load that we're going to talk about. So the HIV targets the cells with those CD4 receptors. The T lymphocyte cells have to composed of 2 major subpopulations that are identified by the cell surface receptors, so CD4 and the CD8. 2/3 of the peripheral blood T cells are CD4, and the normal CD4 cell ranges between 700 to 1200. So that number is important, because as that number changes, it tells us what stage of HIV they're in and how close they are to being in full-blown AIDS. So the HIV just changes the role of that CD4 T cells in the immune system, and basically makes them like little HIV factories. So when, oops, why is this not going? There. So as I mentioned, the CD4 count really determines what level they're in. So you have your primary infection, or your acute recent HIV infection, or acute HIV syndrome. So that's just being infected. They may or may not have, may not be positive for the HIV antibodies yet, and not seeing a change in those CD4 cells. Then with HIV asymptomatic, so they still aren't having any symptoms of anything, but their CD4 count is greater than 500. Then when they become in the symptomatic stage, that's when their CD4 count reaches between 200 and 499, so less than that 500 range. And then they're considered to be in AIDS or have AIDS when it falls below 200. So right at that 200 mark and below is when they're classified as having AIDS. So the primary infection then, as I mentioned, in the infection of the HIV to the development of HIV specific antibodies. So that window period is between 2 to 3 weeks, but can be upwards of 6 months. So those high levels of viral replication is taking place with widespread dissemination of HIV throughout the body and destruction of those CD4 T cells. It can also rest in memory of the CD4 cells. So that's referred to as latent reservoir. And patients will have a dramatic drop in those CD4 T cell counts. The remaining amount of the virus in the body after the initial immune response is referred to as the viral set point. So then when they get into symptoms, when they become symptomatic, these are the things that they will start to see: fever, skin rash, lymphadenopathy, pharyngitis, headache, malaise, nausea, muscle and joint pain. And oftentimes it's just diagnosed as a bad case of the flu. So as you can see, the symptoms are very vague and not specific. So it may be overlooked initially. So with chronic HIV, the HIV positive people enter into a chronic stage in which the immune system can't eliminate the virus despite its best efforts. The disease progression is individual, but on average, it's around 8 to 10 years before major HIV-related complications occur. And then as long as those CD4 T cells remain above 500, they have a high enough immunity for a defense response. So once they fall below that 500 mark, that's when they're really a lot more susceptible to opportunistic infections. So as the gradually declining CD4 count continues, the viral load increases. They have those persistent fevers, night sweats, chronic diarrhea, recurrent headaches, fatigue that just interrupts normal routines. They develop thrush, that oral candidiasis, and then also oral hairy leukoplakia is also another indicator of the disease progression as well. And then as the CD4 cell decrease to lower than 200, as already mentioned, they are said to have AIDS. And then if they drop below 100, then they are significantly at risk for opportunistic infections, and their immune system is just very, very impaired. And then when they are in this classification, they are entitled to disability benefits and housing and food stamps, because there's just not a lot when their immune system is that impaired that they can do. So then you have other diagnostic studies. You have your EIA, your enzyme immunoassay. So that's when the antibodies are detected, resulting in positive results and marking the end of the window period. So the window period, again, usually lasts 3 to 6 months. Western blot detects as antibodies to HIV, and it's used for confirmation. And then, as we mentioned, the CD4 count. And then you have your plasma HIV RNA viral load. It's non-detectable it can be anywhere from non-detectable to highly elevated. And that viral load increases with active viral replication. So if the HIV antibodies are actively replicating, the higher that viral load is going to be. The oral Sure test uses a saliva to perform that enzyme immunoassay antibody test. And then the oral quick rapid HIV antibody test uses a drop of blood. And the results are 99.6% accurate and completed within 20 minutes. So testing recommendations. So healthcare providers that have been exposed will be tested. And then HIV screening is recommended for patients 18 to 64 in all healthcare settings. And so the screen, not that they're specifically testing them, but just screening like high-risk populations and stuff. People who are at risk for HIV infection should be screened for the disease at least annually. So implications, so interpretation of pathogen. Yeah.
Okay, so what I was wondering was, so like if someone was infected with HIV and then they didn't know, right? They just thought they had the flu. How do they know what their viral load was after the window period if they never got tested?
So the viral load doesn't start rising until they get to be more like that symptomatic stage when it's rapidly replicating and that CD4. So the viral load increases as the CD4 count decreases, and especially in the prior to the early stages, or like the symptomatic stage and everything, it may not even be anything may not be necessarily detectable as far as the viral load and the CD4 count in those initial asymptomatic stages. So oftentimes people don't, unless they specifically know they've been exposed, they don't always know that initial level. And it's just a matter of monitoring the levels as they progress.
Okay. So they just kind of just go off of the stages of the 500 and they stick to those numbers, and that's just how it goes.
Yeah.
Okay.
Yeah. Yes. So interpretation then of those positive results. So the antibodies to HIV are present in the blood, and the HIV is active in the body, and the patient can transmit the virus to others. So as soon as they have positive results, I mean, it can be transmitted. And despite the HIV infection, they don't necessarily have AIDS, as we know, because it's more progressive, and they're not immune to HIV. So that those positive antibody results doesn't mean they're immune. It means they have the HIV infection. And then negative results. So the antibodies of the HIV are not present in the blood at this time, or if infected, the body has not yet produced antibodies. So that's that initial period where they may not be testing positive yet, but they're going to need, especially if they know they've been infected, they're going to want to recheck, and then at least, a month, 6 months, whatever the recommendation is. And then they should still take precautions. So the test results doesn't mean that they're immune. It just means that the body hasn't produced those antibodies yet, showing the positive results. So monitoring, again, the CD4 count is a marker of the immune function. So as it progresses, the CD4 count decreases. Again, that normal is 700 to 1200. And then the viral load measures that plasma HIV RNA levels, and it determines the progression. The lower the viral load, the less active the disease and the longer the survival time. So the CD4 count and the viral load are opposite of each other. The lower the CD4, the more it's progressing. The higher the viral load, the more it's progressing. And it does help to be a better predictor of the risk of HIV progression compared to the CD4 count, because the viral load is detecting replication, whereas the CD4 count is more detecting immune responses as far as like how at risk they are for those increased opportunistic infections. Treatment. So it's the CD4 T cell count is the most important to consider in deciding whether antiviral medication should be started. So those antiretroviral meds should be offered to people with T cell counts less than 350, or that plasma HIV RNA levels that exceed 100,000. Already mentioned the viral load is a better predictor of progression, and the goal of the treatment: maximizing and sustaining suppression of viral load to a non-detectable level, restoration of immunological function, quality of life, and reduction of HIV-related morbidity and mortality, which is really the biggest thing, is decreasing those risks of infections. Drug therapy is aimed at decreasing the viral load, maintaining those CD4 counts, delaying the onset of HIV-related complications, adherence to long-term treatment, and highly active antiretroviral therapy, or the HART. So there are lots of different drugs. I don't want you guys to focus on all the different drugs. You know, lots of the meds that end in veer are some of them. And the biggest thing that I want you guys to look at is, here we go, a lot of the side effects. So with all these different drugs that they could potentially be taking, you know, they might be on combo drugs, a lot of different combinations, but they all can have very similar side effects, which include rash, nausea, vomiting, headache, diarrhea, upper respiratory infection, malaise, decreased appetite, depression, insomnia, anxiety, and fatigue. And also many of these drugs can impair the kidney and liver function as well. So they're going to be checking those lab values to make sure that it's not impairing that function, and keeping a close eye on them. It's here in this next slide. So the hepatotoxicity and nephrotoxicity are big potential adverse effects of these HIV treatment regimens, as well as osteopenia, hyperlipidemia. So along with the hyperlipidemia and those things that also go the risk of cardiovascular disease and MI, peripheral neuropathy, insulin resistance, and fat redistribution syndrome. So to the face, arms, legs, and buttocks. Clinical manifestations. So these clinical manifestations as well. I feel like I'm not, yes, here I am. Respiratory, GI, oncological. So they are at increased risk of, I wouldn't really call these clinical manifestations, but more increased risk of developing these problems. So pneumocystis, pneumonia, mycobacterium complex, tuberculosis, oral candidiasis, wasting syndrome, and then oncologic, they are at increased risk of certain cancers, which is the sarcoma and lymphomas.
But they're only at they're only going to get those if they have AIDS.
Yeah,
right?
the lower their CD4, the lower their CD4 count, the more at risk they are for those. Yeah, which is usually more so once they fall under the AIDS umbrella. And then your neurological, neuropathy, encephalopathy, cryptococcus, and leukoencephalopathy, skin, herpes zoster, dermatitis, and folliculitis is also common, can be common. And gynecological, the vaginal candidiasis, and pelvic inflammatory disease as well. So medical management, again, we're going to treat those opportunistic infections, preventing opportunistic infections. So they might be on things such as, you know, your Bactrim or Septra, antidiarrheal therapy, chemotherapy, antidepressants, nutritional therapy, of course, is going to be a big thing as well, too. So a lot of these opportunistic infections, I mean, they're susceptible to any type of infection as that CD4 count drops, but significantly, you know, as you said, like once they get into the AIDS category, some of these things, they just are just highly at risk for it. And that's what winds up killing these patients, is not the AIDS itself, but these, you know, cancers or different infections that they get that winds up wreaking havoc. So nursing assessment, assessing for their risk factors, fluid intake, urinary output, their weight, nutritional intake, electrolytes, skin integrity, pain, vital signs, lung sounds, respiratory status, neurological status. Promoting skin integrity, their bowel health, again, preventing infections, like a broken record, activity intolerance, thought processes, airway clearance, relieving pain and discomfort, improving their nutritional status, and maintaining fluid intake. So then client teaching, so providing client teaching regarding the transmission, so infection control, safe sex practices, well-balanced diet, identifying factors that interfere with nutrition and correcting. So if they have any nausea or anorexia, maybe they need to be on medication for that, as well as mouth soreness as a result of the thrush and stuff that needs to be treated. Medication administration, and again, those potential side effects, signs and symptoms to report immediately, in their follow-up with monitoring of their CD4 and viral load. Emotional concerns, decreasing the sense of isolation, support groups, coping with grief, getting them constructive coping mechanisms, and encouraging activity with rest periods as well. Ethical concerns. So healthcare providers still have fears and anxiety about disease transmission. Nurses should examine their individual beliefs and clarify any controversial issues. If you feel it's something that, you have issues with, obviously that goes with any patient and their beliefs and values and stuff. As nurses, we definitely need to examine ourselves and make sure we can handle them appropriately. Seek support for concerns that can't be resolved, and we're responsible for protecting the patient's right to privacy by safeguarding confidential information. And just like with any diagnosis, it's a violation of HIPAA to give family information regarding a patient's diagnosis and stuff unless the patient specifically gives consent to that. So there's no exception, with HIV and AIDS. We, of course, can't disclose that information to family, and the patient has a right to privacy. And that is it. All right. So, as I mentioned, that's going to be the shorter portion of the less involved portion. Neuro and stroke and all that stuff is going to be more heavily involved. So I do want to point out, let me see here, which one is it? So there is a PowerPoint. Let me just pull it up in the course modules. One of them, this one, the review anatomy nervous system. So I'm not going to go over that one. That's just more for your guys, A&P refresher with the different lobes of the brain and the cranial nerves and all that stuff. Because when we start talking about, stroke and everything and what part of the brain is affected, this is all stuff that you're going to kind of need to refer back to. One thing I do want to point out is this, cranial nerves. So this is something that is really beneficial to memorize the cranial nerves. If you've never seen it before, I find it useful. If you can memorize how to draw this face, essentially, it helps you remember which cranial nerves are associated with what. So it's just, I don't know, I just find it a really useful tool if you haven't memorized the cranial nerves before. It's just beneficial. So that's a big thing I just wanted to point out in this particular PowerPoint. If you look at nothing else, I think you should look at this. So, but I do want to, since we do have time, so that way we're not as rushed next week, I want to go over the, where'd it go? Why am I losing my, there it is. Neuro clinical assessment. So I do want to go over that slide today. My internet, am I being really slow and laggy? Like my internet's been really slow today. All right. So our neuro assessment. So I just need to add that neuro is my absolute favorite, and I just love the neuro section. So I just hope I can give you guys a love for it as well. So with our physical exam, so we know that nursing assessment focus on the 5 major components that make up the neuro exam, which is our level of consciousness, motor function, pupillary function and eye movement, respiratory patterns, and our vital signs. With our level of consciousness, then we go from essentially central to peripheral. or peripheral to central. If they're not responding to peripheral stimulation, then you're going to need to move to your central stimulation, which your central stimulation would be like your sternal rub, and your peripheral would be like nail bed pressure. So obviously, if they're responding to peripheral arousal, then that's better than only responding to your central stimulation. And the appraisal awareness, so the higher level involves orientation to person, place, and time. So that is when we start assigning them the category of alert, confused, delirious, lethargic, obtunded, stuporous, and comatose. So when you're looking at the different levels, of course, alert is our most alert. It's our best category of consciousness. You know, they're responding to, you know, speaking to you, and, you know, less issues. As you go down, then of course, comatose is the worst level of consciousness, where they are not responding to those noxious stimuli. And one thing that people tend to, at least I notice in charting anyway, when you look at people's charting, it's stuporous is actually worse than obtunded, which I feel like in my mind, I feel the same way. Like obtunded to me just sounds worse than stuporous. It sounds like it should be before a comatose state, but it's the opposite. So obtunded is when the response is minimally maintained, questions are answered with a minimal response. And then stuporous is it can be aroused only by vigorous and continuous external stimuli, and motor response is often withdrawn or localizing to stimulus. So stuporous is what's right before comatose. So then you have your Glasgow Coma Scale, which most of you should be familiar with. So our highest level for our GCS is a 15. And then what's the number assigned to a dead person? Yeah, 3. Yep. So the lowest is 3, even for a non-breathing, non-living person would still be a 3. So the lowest is 3, and then the highest is 15. So you have your eye opening, your motor response, and your verbal response are all included in our GCS. So our motor function evaluates the muscle size and tone. You can look for your atrophy or hypertrophy, opposition to passive movement, so flaccidity, hypotonia, hypertonia, spasticity, or rigidity, an evaluation of muscle strength, any movement against resistance. And then you have your abnormal motor responses, which would be your abnormal flexion, which is your decorticate posturing, and abnormal extension, which is decerebrate. So your decorticate posturing is going inward, whereas your decerebrate is going outward. Do you know, I mean, neither one is good. If they're doing posturing in general, both are not great signs. But do you know which one is worse? Is a later sign along the continuum, decerebrate or decorticate?
Decerebrate.
Yeah. Decerebrate is actually a little bit worse than decorticate. And one way to remember that is just if you think of decorticate posturing, decorticate, they're still protecting their core. I mean, they're really not, but it's one way to think of it. At least the body is still like having that involuntary response that they're protecting their core. Whereas decerebrate, they're just going outward and not protecting anything. So your muscle strength rating scale, so 0, of course, would be no contraction, all the way up to 5, which is your active movement, full resistance. And that just shows kind of, again, your decorticate versus decerebrate, and then a combination. And again, the classification of your motor function from spontaneous to localized, withdrawal, decorticate, decerebrate, to flaccid, which flaccid being the worst. Then you have your pupillary function and eye movement. So your function is an extension of the autonomic nervous system, and your oculomotor nerve lies at the junction of the midbrain and the tentorial notch. Any increase in pressure that exerts downward pressure through the notch compresses this nerve. So we're going to assess their pupillary response through size, shape, and reaction to light. Which is the reaction to light then? The direct pupillary response to light would be testing cranial nerve number 3, and consensual pupillary light response would then be cranial nerve number 2. So consensual then is when you shine the light in one eye, the other eye should be constricting too, because we know that our pupils should constrict and dilate together. So assessment of the eye movements, we test our extraocular movement on our conscious patient, which moves through those those 6 fields, which assesses for 3 functioning cranial nerves, which is our 3, 4, and 6 are those is what tests our extraocular movement. And then you have your oculocephalic reflex, which is our doll's eyes that we perform in our unconscious patient. So your doll's eyes, if they're not conscious, and obviously you can't assess their extraocular movement that way. So what you do is you just turn their head back and forth like that passively, and you assess their eye function. So normal would be, they kind of stay, how your eyes kind of like look forward and have that floating effect. Whereas abnormal would be as if they stay fixed and just move with the head, like the eyes themselves don't move, but they stay fixed. And then you have your oculovestibular reflex. So that's your cold caloric. That is what we perform in brain death. That is one assessment that is one clinical assessment that's done by physicians that we assist with to assess to determine their brainstem function. So in doing this, we essentially get a thing of ice water and draw it up into a Toomey syringe, and it is injected into the ear cavity. No response indicates that there is no brainstem activity. So a normal response would be like a shaking of the eyes, or like it should at least look towards, the eyes should look towards the area of the cold stimuli. So absent would be an abnormal oculovestibular reflex that's absent. The test there, I already discussed that, the 3, 4, and 6 that test our extraocular movements. And then here's I don't feel like this is a very good picture of the oculocephalic reflex. It's hard to see, but again, it's that doll's eyes, where it's just abnormal would be where they're fixed and just stay, and then normal would be like the kind of floating response. And then the cold caloric, so absent, nothing is occurring. This would be abnormal, like if one eye is doing something different, but normal is what should be, they should kind of like quiver and then like shake and look towards the site of where the ice is going in. So respiratory function, we know that our respiratory function can be greatly affected by our brain. So you're going to focus on observing their respiratory pattern and seeing if there's any close correlation between their level of consciousness, level of brain or brainstem injury, and their respiratory pattern. And you're always going to evaluate their airway status, of course. So your respiratory patterns, then you have different patterns that are associated with different significances. So just a description of all those different types of respiratory patterns that you might see in the different parts of the brain that are affected. And then vital signs. So of course our vital signs play, our neurostatus can play a big factor with our vital signs as well. So blood pressure, heart rate, and rhythm, and our Cushing's triad. So our Cushing's triad is one thing that we need to monitor closely because it can indicate impending brain death. So as we are assessing our patient, if they have a sudden decrease in heart rate and their blood pressure skyrockets, as well as having a widening pulse pressure. So that occurs when you have a big difference between your systolic and your diastolic pressure. And if this occurs, it is a late sign and indicates that there's pressure on that medullary area of the brainstem that's associated with brain herniation. So this is one thing that you can often identify in a neuro patient. If 1 minute their heart rate is, in the 80s or 90s, and their blood pressure is essentially normal, And then all of a sudden you have a severe drop in their heart rate. Their heart rate just like tanks and is like in the 30s or 40s. And then all of a sudden their blood pressure skyrockets with a really low diastolic. That is a really big key indicator that your patient just herniated. And oftentimes after that period may only last a couple minutes. And then after that period, oftentimes they then stabilize. You know, since the heart does have that capability of automaticity, so then it does often stabilize and their heart rate goes back to normal and their blood pressure might return to normal too. But if you talk to any neuro nurse that's ever seen a patient herniate, they can almost usually pinpoint at what time they're herniated, because you'll see those fast, you know, drastic changes in their vital signs, and then they just kind of go back to normal really quickly. So there's not much you can do at that point, unfortunately, because if you start seeing this Cushing's triad, you can't act fast enough. There's no way to, it's a late sign, and it's just almost impossible to rush a patient to surgery in that amount of time, because it happens so very quickly. So, but then after that is when often you start, they start running tests to determine whether or not they did in fact herniate and are checking for brain death. So, okay,